Well, good afternoon, ladies and gentlemen. We are now ready to begin this session in the perspectives on big data from a public health and virology perspective. And it's my really great pleasure to co-chair this session together with the very famous professor from Columbia, Vincent Rajaniello. Welcome, and please give Vincent a warm welcome because he's been traveling far to be with us here today. Thank you very much. And then I'm very happy to introduce to you the first speakers in a minute. But what I will let you know is that this is really an engaging, interactive session. So first, you will hear the 4 brave presenters who are all distinguished experts in their fields. And they are here with you today to tell you about the work, the travel from an influenza-positive sample in Bosnia-Herzegovina that has become positive at the hospital laboratory, and that will come all the way from there and end up together with, for example, enterovirus positive sample in Amsterdam that will end up with the WHO Euro office in Copenhagen and with the ECDC in Stockholm. But they will all have brief presentations, and we have no question and answer session after each presentation because we have planned a longer joint panel discussion where I kindly invite each and every one of you to engage with your questions to the distinguished presenters. So now, before we start, I would like for you all again, help me give a warm welcome to all the 4 great presenters here on my left side. Thank you. And welcome to our first presenter, who is Dr. And now, sorry about the pronunciation, but Irma Salimovic-Bejic from Sarajevo. Please welcome Irma, the floor is yours.
Thank you for the invitation and the excellent organization of the Congress. My intention here is to give a brief overview of the laboratory surveillance system conducted at the clinical center of the University of Sarajevo in Bosnia and Herzegovina. Before the other items, I would like to say a little bit about the geopolitical arrangement of our country. So, Bosnia and Herzegovina is a country which consists of 2 entities, Republic of Srpska and Federation of Bosnia and Herzegovina, and the third part, which is Brčko district. Federation of Bosnia and Herzegovina, from which I come, has 3 clinical centers and consists of 10 public health departments. So, from the experiences from the pandemic flu season, as well as the international initiatives, it was defined that the strengthening of the surveillance of the influenza system is or has priority activities. So, the following these initiatives, we would like to be a part of the surveillance network to also ensure better quality of the collected data, which can also ensure sustainable surveillance. So, regarding the legislation, influenza surveillance system conducted in the Federation of Bosnia and Herzegovina is regulated by the law on the protection of the population against infectious diseases and the rule book on the reporting of the infectious disease. The surveillance system in our entity for influenza is universal, and practically it is established and mainly based on the paper disease reporting with the possibility of urgent reporting by phone for each death which is associated with influenza infection. All samples that we receive in the laboratory are accompanied with standardized form that are created according to the recommendation of the WHO for Early and SARI samples, and the parts at the bottom of the forms fill the laboratory, and they are about the sample type, test to be performed, and the results of the tests. Reporting of the positive cases on the national level, that is performed by the reference laboratory from which I come for our entity, is done weekly on each Monday in Excel sheets to our cantonal public department for public health department, and also to the Federal Public Health Institute, which is an umbrella institution for all cantonal public departments in the Federation. Following that, there is also an international level of reporting of the results, and there is a Ministry of Civil Affairs which aggregates the data for a whole country and reports the data to the TESI. Laboratory is responsible for virological data, mainly for typing and subtyping of the virus, as well as for the reporting to the Sentinel and non-Sentinel sites. And just to mention that the Sentinel surveillance system was introduced in the Federation of Bosnia and Herzegovina at the end of 2014. As well, laboratory is responsible also for collaboration with the WHO reference center. The primary aim of the presentation is actually to present the time and resources that laboratory staff spent dealing with the influenza virus, and for initial steps that including the reception of the specimens, and for aliquoting, archiving, and performing the real-time RT-PCR, as well as for the recording the results to the lab databases. Estimation was done for 15 and 1 to 15 samples to be performed each week on average. So the average time that laboratory spent for these initial steps, that ending with the results and recording the results of the primary screening, is about 3 hours and 15 minutes. Next step is subtyping, also performed by real-time RT-PCR for all positive samples that we do for influenza B virus and influenza A virus also. After that, there is recording the results to the laboratory database, also analyzing and interpretation of the data, recording and aggregation and reporting to the system. For all these steps about subtyping of influenza virus, the laboratory spent 2 hours and 29 minutes. The third part that I would like to present is virus isolation, which is directly not a part of the surveillance system for influenza, but laboratories spend some time for doing that. Those are the activities of the laboratory regarding the cell culture and hemagglutination without any larger incubation time, so it's just hands-on time, which is per week on average for our laboratory about 7 hours and 30 minutes. At the end, on the summary slide, we can see that laboratory really spent some time to do the laboratory surveillance for influenza, and it is on average weekly for 1 to 15 samples, actually 13 hours and 6 minutes, which is approximately 35% of our total working time. At the end, I would like to thank for all the support that was provided, that have been provided to us from CDC, WHO, CECID, APHL, and RRI for donation of the reagents and some pieces of equipment, and also for very valuable training that was performed to our staff regarding the improvement of the quality management system and biosafety. Thank you for your attention.
Thank you very much, Irma, for explaining to all of us the big work behind each and every one of the positive influenza samples from Sarajevo. Now, next, please welcome Kim Benschop from the RIVM in Utrecht, who will tell us and inform us about the enterovirus surveillance system and maybe also a little about the flu. Thank you, Kim. The floor is yours.
My talk will be more about a question that I had this year about all the surveillance systems that we ran in the Public Health Institute. And it was, how many surveillance systems do we actually need for one virus to get the service we need to our stakeholders? And as most of the talks will be on influenza, being a picornavirologist, I also want to talk about enterovirus D68, of course. So this is the National Institute of Public Health in the Netherlands. We do diagnostic, surveillance, and contact tracing of mostly notifiable diseases such as mumps, rubella, hepatitis, and polio surveillance. We get our data from municipal health centers, particularly the notifiable diseases, from GPs, in particular for influenza surveillance, and from laboratories like for enterovirus surveillance. Now, enterovirus D68 being a respiratory enterovirus, we detect this virus both in the laboratory surveillance for enterovirus surveillance and also in the Nivel, ILI and ARI surveillance. So that's why I combined in my talk a case to present both viruses. So you all heard the talk about Kenneth Tyler, from Kenneth Tyler talking about enterovirus D68 and that it's a new threat out there related to paralysis. And then to my question, how many surveillance systems do we need for one virus? So this is a graph we have getting the data from, does this work? So the lab, the municipal health centers, or the GP, we get the data for enterovirus surveillance, which has a national coverage. We get all the laboratory hospitalized cases, so the severe cases, but we don't really have a case definition. And it's not real time. And also the clinical info is limited for the surveillance system. Next to that, so for enterovirus D68 surveillance, we have Nivel surveillance. And this has a national coverage. It's randomized. It's based on the respiratory case definition for ILI and ARI surveillance. It's real time, but there's no follow-up. So the question was, they don't really cover enterovirus D68 causing paralysis. They gather a lot of data, but we can't really use the data to assess the disease burden of enterovirus D68. So, yeah, here you see that labs, municipal health centers, GP actually have to submit a lot of data to these surveillance systems, but also to databases that we have, like the notifiable disease database. We have weekly notifications. We have shared sequence databases. And they also, for polio, we need to report it to LDMS in WHO. And often, in the case for enterovirus D68, we see actually that this data is in some cases unique, but in some cases overlapping, or in some cases doubling. So labs are sometimes submitting the same data to different surveillance systems. So last year we thought, well, they don't cover AFP really surveillance. We don't have AFP surveillance in the Netherlands anymore. We used to have it, but we don't have it anymore. So we wanted to see if we can reintroduce AFP surveillance specifically for non-polio enteroviruses, where we have a clear case definition, we have testing algorithms, we will look into vaccination or treatment possibilities, and we will have follow-up. But that will mean another surveillance system where the labs have to get the data in. So it's a lot of work for the clinical labs to get the data to all these surveillance systems. And also reporting it so to TESI possibly if there will be a database for that, or if TESI will accommodate non-polio enteroviruses. Next to all the surveillance system, all the reporting, we have to make reports. We have to report to our clinicians what we found, and we have to report to ECDC, WHO, the data that we have in these systems. So if you think this one is complicated, I asked my colleague Adam Meijer, who is actually coordinating the influenza surveillance, what he actually does. So this is a very complicated slide. And this is what he actually has to do per week to get all the data ready for TESI, for all the influenza surveillance systems upstream. And this is not the only thing he has to do. He has to report it to all of the stakeholders involved, all the databases that are out there regarding influenza data. And he has to report this on a weekly basis. So this was when I got this slide from him, I was like, oh my God, what do you have to do just to report for one virus? And there also goes a lot of manpower in it, a lot of money, especially when you have to do weekly reporting. So I ask you this question, how many surveillance systems do we need for one virus? Do we need all these surveillance systems to get the service to our stakeholders, downstream to the clinicians who provide us the data, or upstream to ECDC or WHO, so that we can do our public health task, our clinical task? So isn't one or two or three surveillance systems enough? Can we somehow combine these surveillance systems? Having a limited data set, abiding by the GDPR rules, of course, so that we can do our clinical tasks, we can do our public health task, we can provide the service to our stakeholders. And as I said, abiding by the GDPR rules, the data sharing laws, we also need to regard data ownership and publication rights in these systems. So I hope I can discuss with you later on how many surveillance systems do we need for one virus, not only influenza, not only D68, but also norovirus, as I saw the talk from Jan Vignier yesterday, of all the surveillance systems they have for norovirus alone. So thank you.
Thank you so much, Kim, for giving us this excellent presentation on all the challenges and fun of being at the reference lab site. Thank you.
All right, our next speaker is in the WHO Emergencies Program in the WHO Regional Office for Europe, and that's in Denmark. Please welcome Caroline Brown.
Thank you very much, Chair, and thanks very much for this invitation. It's always nice to be interacting with clinicians, and WHO, we know we need to do more and more of that, so I'm very happy to be here. And I'm also happy that the previous two speakers spoke about influenza, so hopefully my talk will then be a little bit more understandable. Because I'm not going to tell you whether we only need one system, because I think we struggle with that as well, but I'm going to talk about one very important aspect of influenza surveillance, and that is how the virological surveillance contributes to a very important public health product, which is the seasonal influenza vaccine, and how big data, i.e. sequence data, how that fits into that whole process. So I'm here today with Dmitry Peryaslov from my team, who helped me, with whom I developed this presentation. And just to say, next presentation is from Mike Catchpole from ECDC. ECDC works with the EU member states, and in where I work at the WHO Regional Office for Europe, we work with 53 member states in the WHO European region, including EU countries, and we work very closely with the ECDC. So this is just a quick overview of my presentation. I'll say something about why influenza is a public health priority, what is the production process for seasonal influenza vaccines, and how does global influenza surveillance contribute to that? How does genetic sequence data contribute, and also say something about next generation sequencing, some challenges, and a few conclusions. So influenza is a public health priority because both pandemics, which occur at intervals throughout history caused by a new influenza virus, both pandemics and epidemics cause high morbidity, mortality, and economic costs. And once a pandemic virus has traveled around the world, the influenza A virus stays with us as seasonal influenza and comes back year after year. And the last time that happened was in 2009. The H1N1 virus emerged and is now co-circulating with the other seasonal influenza viruses, H3N2, and influenza B viruses. So WHO, I'll say something now about current seasonal influenza vaccines. And WHO recommends that certain persons at higher risk of complications due to influenza be vaccinated against influenza. And these are pregnant women, persons above the age of 65, people living in a long-term care facility, persons with chronic conditions, and children between the ages of 6 months and 5 years. So current seasonal influenza vaccines, to understand the surveillance, you need to understand the vaccine. They contain representative strains of the seasonal influenza viruses. And the most commonly used influenza vaccines are inactivated and unadjuvanted. And the production takes 6 months. Because influenza viruses are constantly evolving, a process known as antigenic drift, the vaccine strains are updated regularly. And the production cycle of the vaccine, which as I said took 6 months, is tailored to the seasonality of the northern and the southern hemisphere season. So this slide shows you something about the evolution. This is the hemagglutinin gene, the main antigen on the virus, and it shows the phylogenetic tree, the evolution from 1968 up to 2018. So 1968 is when it emerged, the pandemic virus. And what does this evolution mean? It means that there are antigenic changes, and it means that we have to update our recommendations on which strains to include in the vaccine. So these charts, the top chart shows you how often changes have been made to the H3N2 vaccine, and then the middle section is the H1N1 virus. Before 2009, we had a seasonal H1N1 virus, and then since 2009, we've had the new pandemic virus, and that's been updated once since it emerged. And then the bottom shows the influenza B viruses, and the switch from orange to pink is a switch from the B Victoria and to the B Yamagata lineage. So as I mentioned, the vaccine production process is tailored to seasonality. So the Northern Hemisphere cycle, the Northern Hemisphere season is from about November to March, April. So you want to vaccinate people in about October, and then we count backwards because it takes 6 months to produce this vaccine, which is still mainly produced in eggs. So in September, you want to have product release and shipping. In August, filling and packaging. Between June and July, testing and licensing. And from about October through to May, you want to select which viruses should go in the vaccine and start the production process. And where you can see the little WHO logo, February, that is when we release our recommendations for the next Northern Hemisphere season. And at the bottom, you can see that in September, we release recommendations for the next Southern Hemisphere season. So now I'll talk about the surveillance that is contributing to this, and the surveillance is done by the GISRAS, the Global Influenza Surveillance and Response System. This is a global network for year-round surveillance and virus sharing so that WHO can make these recommendations. And year-round national networks, they collect samples, and these go to the national influenza centers where they are analyzed, and the national influenza centers, they share influenza viruses and sequence data. They share influenza viruses with WHO through a global network of collaborating centers, and they also share sequence data with databases such as GISAID. The collaborating centers, they conduct advanced characterization, and they develop vaccine viruses. And that then leads to the recommendations in February. And WHO has been providing recommendations for which strains should be in the vaccine since 1973, and this is a typical product on our website, and these are the recommendations for the season that is imminent. And I'm going to focus on the surveillance, the virological surveillance that is being done by the national influenza centers and the collaborating centers. So one point to realize here is that there is a very short window for characterizing circulating viruses in our region, because the influenza season in our region, it typically starts in November or December, and that's shown by the dashed line there shows 10% positive samples, which is when we consider that the season is starting in the region, so that's in week 49. But by week 3, all viruses should have been shared with the collaborating centers so that they can conduct the advanced analyses to be able to make the recommendations in week 8. And you can see in this example, the season didn't actually peak till week 5. So it's a very short window, and I've just boxed this window here. So during this short window, national influenza centers and the collaborating centers, they are conducting a combination of antigenic and genetic characterization of viruses. They share the sequence with GISAID, as I mentioned. And the WHO collaborating centers, because they are doing advanced analysis, they may already know that there may be a particular virus that is showing some characteristics that may suggest that the virus has changed or drifting, and they guide the national influenza centers. In this period, they will contact them and say, look, we're picking up such and such a virus, could you please see if you have any and share that with us. So this slide is an example of how genetic sequence data is contributing to the vaccine strain selection. Although the recommendations of WHO are still based on the antigenic characteristics of the viruses, all this is supported by sequence data, because this helps you identify changes in the virus that may be associated with antigenic drift. So sequencing has proven to provide information that will help you compare the gene sequences of circulating influenza viruses to the sequences of the vaccine viruses, and it provides information on amino acid changes with biological significance, such as drift, but also antiviral resistance. And it can help you to look at the geographic distribution of genetic groups. And what you can see on this slide, the figures on the left is a phylogenetic tree of influenza B Victoria viruses, And the matrix with the colors, it shows you which geographic region the virus has been detected, and that the colors, they correlate with the map of the world. And this means that we're using this sequence data to follow evolution and spread over time. The pie charts at the top show the proportion of new genetic groups of B. Victoria viruses related to a new deletion mutant, and the graph shows how this mutant has become dominant over time. So now I'll switch to big data, which was really what I was asked to focus on. So how is NGS, next generation sequencing, how is that being utilized? And we think it's really transforming virologic surveillance. So traditionally, until a few years ago, genetic characterization was performed by collaborating centers, but in recent years, more and more national influenza centers are conducting sequencing, and that includes establishing NGS pipelines. So NGS sequencing can save of specimen, it saves time, and it allows a shift from virus isolation, which is very labor intensive and also costly, to a sequence-first approach. So the diagram on the right shows the isolate first, sequence second approach. So first you would have the specimen collection, and then virus isolation, and then the antigenic analysis, and then you would characterize genetically those viruses of interest. But techniques like NGS are turning that around. So first you can sequence on the specimen and then decide which viruses need to be sequenced and then characterize those. So it reduces the number of viruses that you need to isolate and characterize. Moreover, NGS is high throughput, and this increases the availability of data for strain selection, as well as predictive modeling. As I said, there's a very short time window for generating data. And already mentioned, it helps prioritize viruses for isolation and antigenic characterization. And there's also economy of scale, because you can use it in combination with Sanger. But there are challenges. There are still high costs, although it is getting cheaper. And you see on the graph on the right that most sequence data from NGS is generated by countries in North America and Europe. Data analysis is extremely complex and is also variable between different bioinformatic pipelines. You need enormous data storage capacities, which is also expensive. And it's still an emerging technology, so the choice of platform is quite complex. So in conclusion, antigenic characterization of influenza viruses is the cornerstone for WHO recommendations on strains to include in seasonal influenza vaccines. But especially, I think, the sequence-first approach, so of more clinical specimens by NGS, provides a better understanding of the proportion of various genetic groups in circulation and allows more targeted virus isolation and lower numbers to cover the antigenic characteristics associated with the different genetic groups. NGS can improve data timeliness and data availability for the WHO consultation on seasonal influenza vaccine composition. But as already mentioned, it's also resource intensive and requires a high level of expertise. Because of that, WHO is currently developing a guidance particularly for national influenza centers, to help them determine what the options would be for them to establish such a platform. And then just finish with some acknowledgements. Obviously, all the national influenza centers in our network, and I'm happy to see some of them here today. The WHO European Region Influenza Network, which includes the EU network, coordinated by the ECDC, the WHO Collaborating Centre at the Francis Crick Institute in London, John Macaulay and Rod Daniels, and the ECDC influenza team led by Pasi Penttinen. Thank you very much.
Thank you so much. Our final speaker is Chief Scientist at the European CDC in Sweden, Michael Catchpole. And he's caught by his seat.
Thank you, and for my next party trick. Thank you very much to the organisers for inviting me. It's a real pleasure to be here, and Taya knows there are some invitations I just can't refuse. So it's a great pleasure to be here. As Caroline mentioned, the work that we do on influenza surveillance at the European Centre is done hand in hand with our colleagues from WHO, and I'm just showing off our brand new joint branding for work. So I've been asked to talk about big data. The golden thread for this session is influenza. My title, Big Data, Better Information? We will see. And I think I would really look forward to the discussion on that. So just to put it in a public health policy perspective, I don't need to tell you, but influenza is a major cause of morbidity and mortality. There are tens of thousands of deaths due to or contributed to by seasonal influenza every year. And of course, pandemic influenza is the only infection which really is a global response plan. So it's really high on the public health policy agenda. And public health policy relies on many different sources of evidence, but surveillance is a major source of evidence for driving policy. And I hope as the talk goes on, you'll see how we use the data, what sources of data we use, and how big data may make a difference to the future. So we've recently had an external evaluation of the ECDC's influenza surveillance systems. A lot of positive comments, but there were clearly some challenges and some issues highlighted. And these, for me, are the policy challenges for influenza that I think surveillance needs to address, and we need to look to see the extent to which big data can help us with that. So we need accurate and rapid assessment of the burden and severity of influenza, be it seasonal or pandemic. And one of the things we don't want to do is to have to switch monitoring systems between seasons and pandemic situations. It just doesn't work. I remember in 2009, 2010, it was a little bit like building the aeroplane after it had taken off. In the UK, I was working at the National Centre in London, and we had to put together a system for monitoring severe disease in hospital and intensive care units, and doing that in the middle of the pandemic was not the most comfortable place to be. So we need systems that can translate from seasonal to pandemic. But we need accurate and rapid assessment of burden and severity. Why? Because we need to make sure that our health service planning is proportionate. We need to know whether or when and to what extent we're going to have to close down routine services. We're going to need to have to gear up services to deal with a more or less severe seasonal epidemic. And we need a proportionate pandemic response. I mean, my personal view, I don't mean to be overly controversial, but my personal view is it took us collectively far too long to recognize or be confident about how severe or not severe H1N1 was. Strengthening and evaluating vaccine programs. I mean, the mainstay of prevention is the vaccine. Caroline's already covered the issues relating to vaccine composition, but other issues I would raise is we have target groups, priority target groups, but we know that in Europe, in most countries, most target groups, we're not achieving the coverage we need. And what we need is probably better evidence for policymakers to strengthen their resolve to address these things. And I think we can always learn more about which priority groups we should put top of the list. Post-licensing vaccine evaluation, you may well be aware that the European Medicines Agency 2 or 3 years ago shifted the focus for assessment of influenza vaccines in Europe to actually brand-specific post-licensing evaluation. And that poses some real challenges for us in terms of how do we gather the data that can provide robust, brand-specific estimates of vaccine effectiveness. We commissioned a study on this, and we currently believe that it would require a quantum size scaling up of studies looking into vaccine effectiveness in order to provide robust brand-specific data. And then I put here long-term and non-specific effects of vaccination. I think that this is an area that is going to become more important over the next few years. There's a lot of intriguing data looking at vaccine effectiveness and the possible interaction between previous vaccination and effectiveness of vaccine in current season. There's also obviously a lot of discussion about the importance, the role of childhood vaccination with the UK and Finland, particularly in Europe. I was going to say leading the way. That's perhaps a slightly subjective view, but I would say leading the way. And the role of antivirals. I'm sure you may all be aware that a few years ago, a Cochrane review really brought into question the effectiveness of antivirals, caused an awful lot of uncertainty and concern. And I put here the randomized controlled trial fallacy. I think the problem is that the randomized controlled trials that would be needed to really answer the questions definitively will be hard enough and expensive enough to run in a seasonal influenza season. But in a pandemic, we're never going to do it. We're going to have to make use of good observational data. And surveillance is one of the sources of those good observational data. So that's what I think the key policy challenges are that surveillance can help us address. Now I'm going to quickly rush through influenza surveillance in the EU because I think you've probably heard enough of it. There are 17,000 GP practices, 2,000 hospitals, thousands of laboratories, including you here. And just to make it clear that for me, for all of us working in ECDC, the bedrock of influenza surveillance is good quality virological data that you all provide. Without that, we wouldn't have the quality of data, the evidence base for policy that we do have. We collect clinical indicators, laboratory confirmations, severity assessments every week. That's our new building in ECDC in Stockholm. Every week, we, with colleagues in WHO, produce Flu News Europe and risk assessments, and we produce annual reports and publications. We also, and I'm including this in the talk on surveillance because I think it's relevant to the big data discussion, undertake annual vaccine effectiveness estimates through a commission service with iMove Network, and that is one of vaccine effectiveness studies are one of the factors that are influential in vaccine choice, and then the circle goes on. You will hopefully all have seen some of the outputs. So this is an output summarizing 2018, looking at influenza intensity, looking at viral strain distribution, and you can see at the bottom there the data coming from laboratories about specimen submissions and positive identifications, more data on virological monitoring. As I say, this really is the bedrock for us. And more recently, following on based on work actually done in Denmark. Yes, wow. Looking at mortality, we now have good comparable mortality data from many countries in Europe, and as you see here, we see that actually excess mortality is typically associated with years where there's an excess, where H3 predominates. And I think this slide for me is really telling in terms of the impact on mortality and the differences between H3 and H1 years. And most recently, we've started to get a bit better at the EU level in monitoring severe disease. So these are data from 12 EU member states that are providing on a regular basis information on cases of influenza, laboratory-confirmed cases of influenza admitted to intensive care units. So you can see the seasonality, the epi curve on the left, and then on the right-hand side of the bar charts show the distribution of the different viral subtypes by age group amongst severe cases. And we're just beginning to get data through surveillance, which I think is quite an achievement, rich enough data to start looking at risk factors for fatal outcome. And again, this feeds back into where should we prioritize our efforts if we are struggling to achieve vaccination coverage targets, where should we focus first in terms of who are most at risk. So, oh, and last but not least, as I mentioned before, vaccine effectiveness studies. We use the test negative case control study design, which is a fantastically efficient way of undertaking vaccine effectiveness studies. But as I mentioned before, to move, even using this study design, to brand-specific vaccine effectiveness monitoring would mean a quantum-sized scale-up in the amount of data we would be asking you all to provide. So, what are the priorities for strengthening influenza surveillance? This list is derived to some extent from the external evaluation that I mentioned that was undertaken of European influenza monitoring, coordinated by ECDC, and a bit of a personal view. So we have here improving primary care surveillance, comparability of data. Such variation across Europe, it is always a struggle to really compare. Hospital-based surveillance, we really need rich data to get a better handle on who's most at risk of severe disease, who's most likely to actually benefit from increased efforts in terms of vaccination, and also get a better handle on how severe the next pandemic will be. And similarly for intensive care unit surveillance, mortality monitoring, we still need to increase the number of countries that take part. Web and social media-based surveillance. One of the challenges is to get as early warning as possible of the beginning of an epidemic and to assess the severity. And there's been some interesting examples of web-based, social media-based monitoring, self-reporting by the public, which is beginning to show some promise, I would say. We need to expand vaccine effectiveness data collection, and we need to improve our understanding of the long-term effects of vaccination. And I haven't mentioned what's the impact of influenza vaccination on antimicrobial resistance. Another interesting debate. If we look at this in terms of big data, I think the things there in red, I think that's where big data, and I'm primarily I'll explain what I mean by big data, because big data means different things to different people. Caroline has talked about one of the most important forms of big data, and that's whole genome sequencing data. But there are many other forms of big data that we can and will use to address some of these challenges. And if I run through those now, you'll see. So, first of all, what are we doing about it in ECDC? Well, actually, next year we launch 2 proof of concept studies, because there is a lot of skepticism about e-health and just how easy or not it will be, not simply to capture e-health data at a national level, but then to pull it together at an international level. So we're responding to the challenge with a couple of proof of concept studies. We're looking at surveillance of pan-drug resistant bacteria, but perhaps of more relevance to this discussion is we're looking at surveillance for risk factor to support risk factor analysis for 5 of notifiable diseases, by which I mean diseases that are reportable at the EU level according to EU legislation, and one of those 5 is seasonal influenza, and we are hoping that through the proof of concept studies we will be able to demonstrate the feasibility of collecting more information on clinical presentation. Well, you can see the list there, but that starts to take us to potentially being able to collect much larger volumes of data, and hopefully large volumes of data more rapidly than is currently the case. Not that influenza surveillance is slow at the moment, it's amazing. This is in the context of a much bigger push within the European Union. The European Commission is pushing digital transformation of health and care, because we all love Commission communication numbers. COM 2018233 is the one to really focus in on. I promise you, it's a good read. Which is about digital transformation of health and care, and as part of that, there's a major push for the exchange, e-health exchange of patient data across borders, starting modestly, I have to say, starting with the exchange of summaries, discharge summaries and prescription data, but as you can see, 22 member states have committed to the exchange of patient summaries and e-prescriptions by the end of 2021. 2 have already started, Estonia and Finland. Estonia are well ahead of many countries in Europe in terms of e-health capacity and capability. And as you see from the map, other member states will be joining. So exchange of electronic health record data across borders in Europe is a reality. It's happening now, and I think it's going to increase exponentially. We've also been involved in ECDC in a project which is funded as part of the IMI initiative. Oh, it's flashing pink. I'm nearly finished. Which accelerated development of vaccine benefit risk collaboration in Europe, the ADVANCE project. And just to mention that part of this was looking at the use of big health data for improved vaccine safety and effectiveness studies. This slide is just to remind me to tell you that part of that project was proof of concept studies looking at the extraction of data from myriad different health systems and systems which allows the coding to bring it together. And then finally, I mentioned to you self-reporting. Just 2 examples. In the UK, the Flu Watch system, where enrolled participants report on a regular basis on flu-like symptoms, and GripeNet from France, again, which is an impressive data set that they generate in France through that. And influenza surveillance, big data, the role of whole genome sequencing, previous presentation. Caroline, I thought, very elegantly demonstrated that. And finally, just a huge thanks to colleagues who've provided data, the European Commission colleagues for some of the slides, and more particularly yourselves. And I'm sorry, perhaps I should have virologists, because it's a tribal thing. I'm sorry, I'm an epidemiologist, so just excuse me. But anyway, thank you.
Thank you so much, Matt. A great presentation, and thanks to all of our great speakers. And now, please, everybody, the floor is open, and the panelists here are ready to answer all your questions. So I'm hoping you're all engaging now, and there must be a lot of questions here in the auditorium. It's all about ice breaking. So who is the bravest one who wants to start? Heli, thank you. Right over here.
Thank you for fantastic talks. So I'm Dr. Heli Harvala, Finnish living in England. I have a question on NGS big data, because certainly several hospitals in England and many other European countries are bringing NGS into the diagnostics. It's coming into the hospitals, and hospitals are producing huge amount of data. So is there considerations at national level and international level? How are we going to collect that data? And of course, before that, it will have to start with standardization. But I hear a lot of discussion how this data is produced in the big centers somewhere in Europe, but I believe this data is going to be produced in hospitals.
So, good question. We've been doing a lot of thinking on that in ECDC. I mean, we've actually this year, for the first time, we have one infectious disease where monitoring is entirely based on whole genome sequencing. It's listeria, perhaps not the top of the list of interest for the audience here, but we've actually based European surveillance on that. We're looking at, as we scale up to much higher volume diseases, so to speak, how we're going to deal with that. And we're looking at a variety of models. We certainly can provide some capacity within our systems for that. But we think that the long-term solution, and particularly so this is linked to, I think, the laudable move for sharing of sequence data through Sanger and the European, I can't remember the acronym, I can never remember the acronym, but the big centre for storing and collating sequence data in Europe, that we're one of the options we're looking at is a collaboration with them so that they will hold the data. Because in reality, for surveillance, what we need is some kind of summary information. When we get to outbreak investigations, then you may well need to access the actual raw data. But that'll be a smaller volumes of data, and we certainly have the capacity to do that. But, you know, it's an evolving thing, and there are various different models with federated database models, but I think one of the things I'd like to see this go hand in hand with is greater sharing of this sequence data.
Thank you, Mike. And we have the next question here in the first row to the left. Peter Coyle.
Just a very simple observation. I work in Qatar, and there's a big nationality shift around there. And the two things that I would like to see on the hospital system is a vaccine history and a travel history, you know, actually being captured in the system. It's hit and miss whether somebody puts it in or not. So vaccine history, travel history, time of travel, if you've got 150, 160 nationalities. So the question is, do public health bodies speak to the manufacturers of the IT systems to ask them to put these things in?
I don't know, did anybody else want to have a go at that first? So for many years, when I worked in the UK and latterly as the director at the centre in Colindale, I spent a lot of time doing exactly that, trying to make sure that the voice of public health was heard at the tables where the dialogue was going on. I mean, the investment in electronic healthcare systems is driven particularly by clinical interest, quite rightly so, and commercial factors there. And I did manage in the end to convince the architects of what was then the NHS IT strategy, which has not necessarily covered itself in glory, about the importance of actually considering public health. But talking to colleagues around Europe, it's an uphill struggle to get that voice heard. But if we don't do it now, we're making quite a lot of effort in ECDC. We're in dialogue with our colleagues in the directorates for, you know, IT systems that are leading these projects I showed you there, to make sure that they're aware of the public health benefits. Because I think that e-health systems offer significant benefits to healthcare, but I think they offer quantum level benefits to epidemiology and public health. And that's the message I try to get across.
Thank you, Mike, for answering. And now I hear a request for more data actually from the virological side. I think that's a quite interesting development. Thanks, Peter. That was implicit in your question as I hear it, and it was great. Next question, please, Yannick.
Yes, I would just like to hear which steps are being made by the public health institutions to ensure compliance with the new GDPR rules, which is causing a lot of caution in a lot of countries at the moment.
Yes, so at the national level, at the RIVM, we are gathering all the data of the surveillance systems if they abide by the GDPR rules. We are not there yet. We still need to get all these, how do you say it, PIAs, all these acronyms related to the GDPR. But we are, in our systems, we are looking if they are GDPR compliant. If they are not, we need to change them or, yeah. So we are working on it in the public health systems to see which data are we allowed to gather from the clinical side.
The GDPR, ECDC, of course, we look at this because we gather data from many different countries. GDPR is not, we've been bound to comply with European Commission data protection requirements for several years, and in fact they are pretty much the same as the GDPR. So we worked with that framework for quite some time, and actually if you look at and I think the trouble is that if you look at the GDPR, it actually is moderately permissive to the collection and the use of personal data, the processing of personal data for legitimate public health, public interest purposes. But I think the devil is in the detail, and the interpretation is causing headaches all around Europe. I'm aware of that. We at ECDC have had briefing sessions in our advisory forum where our legal services have given some advice on that. And I understand the concern, but my understanding, and I did a lot of work on this again in the UK before I came here as well,
is that we should not perceive it as a massive barrier to doing legitimate public health surveillance.
Thanks for that comment, Mike. And please, Eva.
Eva Broberg from ECDC. I listened carefully to the presentations and didn't hear much on POCTs. We had a wonderful session here on Tuesday focusing on POCTs. There are multiple companies now presenting upstairs their new devices, and we have heard in our influenza annual meeting outside this conference now on how POCT devices already affect the surveillance data that we receive at the European and global level, meaning that there are less subtyping data available, and also meaning that there are less samples flowing to the reference laboratory level, and therefore also less material to look into the antigenic characteristics, and less viruses available for the vaccine composition production. So any comments to this from the panel side, how the POCT data could be first of all captured in the surveillance systems, so that those data produced in the hospital levels, in the hospital laboratories, because those data are not necessarily linked to the national surveillance systems, could be better linked, and then how to work towards the better quality of the data, so that we don't lose the details that we currently have in the very good influenza surveillance system. Thank you.
I can say something about, a little bit about that, Eva. I mean, the approach that we've been taking at WHO and helping countries establish, and as has been established in many EU countries, is a sentinel approach. So you have selected GPs or selected hospitals, and they are involved in the surveillance. And if that surveillance requires that we need viruses, then that is something that is standardized, and it's a cornerstone of surveillance. I think. So it's a question of the additional viruses or the additional testing that's being done at the hospital level. To what extent is that part of the surveillance needs? So there's the virus aspect, and then what clinical and epidemiological information. So I think it's something we have to look at carefully. How should that be integrated in surveillance? And I think it's a discussion that's ongoing at the moment.
Thank you, Caroline, and the gentleman here in the front.
Yeah, so this morning we heard on the talk about vaccines, about the use of reverse vaccinology being introduced. And we hear this afternoon about in the influenza situation where we're trying to move towards reverse vaccinology, reducing the amount of antigenic evaluation and relying upon sequence information. How quickly do you think it might be before we actually will do pure reverse vaccinology in the flu vaccine field?
Okay, my Dimitri is saying many years, but please take the microphone.
Yeah, I think the technology is not for influenza is not yet there, and it will take some time to get to that stage. But technology is advancing.
Thank you. And then first one, Peter in the first row, and after Bert.
Just a comment on that. I used to sit on the advisory committee for GM modification, and one of the big things is if you have a reverse vaccinology vaccine, having it labeled as a GM vaccine is a big public health issue. A lot of people do not like GM, So it's not just a technical issue, it's a sales issue. And a lot of the companies, part of the regulations is they have to state that, and they're trying to get exemptions from stating that because it puts the public off.
Thank you all very much for the talks. I have actually two questions, so I could do this simultaneously. One question is about the big data. We live, I don't know how many people live in the European Union, which you cover. It's over 400, depending on what you read, 400 or 500 million people. So we probably have too many data. So you could also say, if storage of data is a problem, you just need a fixed amount of data to make your conclusion, right? That's what I would assume. If you would have 1,000 sequences, 10,000 sequences, do you need 100,000 sequences by NGS? There is something, there should be a limit, right, which is reasonable. That's one question, if you could comment on that. And the second question is, you gather a lot of information, not only about influenza, but also other viruses. But most importantly is also to provide rapid feedback to the laboratories to say, we collect the data, this is what we do with it, we scramble, 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 and next week, or preferably tomorrow, this is the conclusion so far. In the case of an outbreak, it's different. I mean, an outbreak, you probably need only a few hundred of sequences to start knowing there is something going on. So could you comment on both points?
Yes. So in terms of the big data, and particularly e-health and the capacity to collect larger volumes of data, then I think there are qualitative and quantitative issues there. So one of the issues about e-health is it has the potential to reduce the burden on reporters, which is, I think, a universal good. That certainly the aspiration is not to collect all e-health data on every individual in the EU. You have to look at what the objective of surveillance is. Now, if the objective is, and this isn't so much the case for influenza, but if it's to detect outbreaks, then actually comprehensive coverage is important because you will detect outbreaks quicker at an earlier stage and be able to interrupt. But if it's surveillance to inform programmatic strategic work, then a sentinel approach may be, well, so I mean, I think there is thought going on about this. It's not simply fantastic, there's all this, let's take all this data. You know, there has to be a bit more strategic thought about it.
Yeah, but that relates to the comment Haley made. I mean, we're all producing data, and Eva mentioned the issue with point of care testing, that you don't have the strains. We have probably, as diagnostic laboratories, too much data for you. You can never collect the data, that's one thing. Aside, technically, you can collect all the data, but probably you also don't need all the data to fulfill your task as a public health organization. That's my point. You know, so we produce too much data. I mean, if I would produce in my city 100 sequences of NGS, who cares? You know, the 100,000 then plus 100 makes no difference.
I completely agree, and there are a number of EU surveillance systems that are based on collection of data for, say, a 3-month period or a defined subset based on the key objectives. So I don't think anybody in ECDC or WHO is looking to collect everything, and there is a sentinel approach taken based on the objectives of surveillance. The second question you had, remind me.
Feedback.
Feedback, yes, yeah, feedback. So
outside influenza I get every week. You know, I see all the different colors.
Yeah.
And as long as the Netherlands is, we are green, right? And nothing is happening, so I'm happy. So.
Yeah, sure. Yeah, and that's a huge effort. That's quite a machine to do that. For many other systems collected at a EU level, the data submissions are quite often on an annual basis. So it's not quite such a real-time system in terms of provision of data. But the feedback, we're continually looking at how we can speed that process up. But I wouldn't say that we've achieved perfection there at all yet. No, but I understand that.
But I think that it's very important also to make us more, well, I don't know, make us more happy is maybe the wrong word, but I mean, you almost count how many influenza there are every week. In the United States, they count how many children die every week. But I don't know how many measles infections are in every country every week, for instance.
No, we do tell you every month, and and the other point is that we've introduced something called the Surveillance Atlas on our website. I'm just talking about what we do, but where actually we make the data available as quickly as we can for you, where you can interrogate it and run your own reports. But the synthesized, interpreted reports are still taking longer than I would like. Yeah. So okay. Yeah.
Thanks very much. It's the gentleman here in the back who has patiently been waiting. Thank you.
You're welcome. I have a question for Caroline, because she mentioned in one of her nice slides that immediately after the start of an influenza epidemic, there's just a brief period of time to characterize these viruses that are responsible for that specific season. However, a few years ago, the Muslim calendar resulted in a Hajj right in between the northern and the southern wave of influenza. And because of the case definition of MERS coronavirus, we tested lots of returning travelers from the Hajj in the Netherlands, and most of them who fit the case definition had flu. And therefore, Adam and I at the Public Health Institute used this data to have a sneak preview of what was coming. We knew percentages of circulating antiviral resistance and might even have a clue about vaccine efficacy prior to the first wave or prior to the season. Are you thinking about using such mass gatherings of international people to have a similar sneak preview of what is coming instead of measuring the disaster when it's happening?
Yes, that's very interesting, and I guess then if the Netherlands is able to do that, then that data would also be shared. So that would of course be useful.
But Hajj is now, because of the shifting calendar, is in August, so it's not useful anymore.
No, exactly. But I mean, there is usually for this kind of mass gathering, there is surveillance set up. So we would have, I would think we would have access to this data from such mass gatherings. If there's any outbreak in a situation like that. For example, there's a lot of attention when there's seasonal influenza in northern Syria among refugees. So we are any kind of mass gathering, outbreak situation in any kind of mass gathering or emergency, humanitarian emergency, we are conducting surveillance and looking at that.
Thank you, Caroline. And Heli, please.
Yeah, I would like to bring the nosocomial hospital-acquired infections to this picture. This e-health planning looks fantastic, but I couldn't see that it would have included hospital-acquired infections. And I just wonder if this is something, since we have a lot of improvement in surveillance for bacterial infections, but so far viruses at the international level haven't really been considered that much. So is this something that perhaps could be considered, adding a date of hospital admission or something to the form that then it could be calculated?
Well, yes. I mean, we're starting with 2 proof of concept studies, and of course the study looking at highly resistant bacteria, often they're acquired in hospitals. So actually, we will be looking to some extent at that. It's bacteria. I'm sorry, but it's we'll get to the viruses eventually. Yeah. So we're starting with 2 projects, but we see that we hope this will expand. Just to make the point about mass gatherings, there's a really good, extensive literature on mass gatherings. As Caroline said, WHO, national institutes, ECDC, if there are Olympics, and I'm very much involved in the systems for monitoring what happened during the London Olympics back in 2012. If you look at the data, typically you see gastrointestinal outbreaks. They've not been up until now, perhaps the one example you've given, a useful gauge for influenza or severe respiratory tract infections. They just haven't. Perhaps they've been at the wrong time. But there is quite a good literature on that. And the other point I meant to say, point of care testing, take Ava's point about the concern about loss of flow of specimens to laboratories. But of course, it does mean that perhaps the validity of clinical reporting, ILA and IRA, SARI and other things will be better. So there's kind of, there's good and bad. There's yin and yang in all of these things.
Thanks, Mike. And there's a question here, Marcus, in the back, Emma.
Yeah, thanks. Just probably for all of you, how good is the evidence that e-health is really improving our surveillance system? I mean, we're always aiming at the best evidence available, and it's, I think, a rather young discipline. And who's the drivers? Some stakeholders, IT nerds? I don't know. So do we have good data that it really is an improvement?
Well, in a way, the fact that I referred to them as proof of concept studies is a little bit the answer to the question. That we're looking to do that. We believe that it's the way of the future for a variety of reasons. One is because it offers the opportunity to reduce the burden, which I said of itself is a good thing. It also offers the potential for richer data and quicker data. But as you quite rightly say, we have to prove that's the case. And I'm just desperately trying to think if we've got any examples of that. And I suppose that for me, the example I know best is the primary care surveillance system in the UK, which is based on weekly, if not more frequent during things like the Olympics and the flu season, extraction of general practice data, which then flows through to the national centre. And I would say that is an e-health surveillance system which has proven itself over many years. So the answer is yes, there are some really good examples of that, but I think to move to the next level of added value in terms of rich data from other sources, like the sort that Halle was talking about, that's what we're starting to look at now.
Thank you, Mike. And there's another question here from Bert. And Beard, are you also questioning, or did you just raise your hand? Oh, you're just dancing. Okay, thanks.
We heard from Kimberly all the challenges Adam has on filling all these reports and how crazy he can. How I can imagine he's getting crazy with filling all these different IT systems. How do you envision that you do this across European countries? I mean, European countries have the tendency to be European, but once you cross the health system or over the border, everything changes. How do you envision that this will work? And did you do some kind of risk assessment that every country implements your IT systems?
Well, I suppose the simple one-word answer is standards, but I think it's no coincidence that countries such as Estonia are actually ahead of others. They've got a smaller health economy, a smaller IT system. It's easier to come up with, and then you scale that up to countries like the UK, which has tried several times to put in universal e-health systems with not complete success, if I can put it that way. And then you scale it up to Europe. So the challenge is enormous. But then on the other hand, we're all used to being able to use Amazon or Google or other things to access and get information from countries all over the world. So the problem is going to be around standards, and I would be the last person to say that's going to be easy. But that's one of the things we're going to look at in the proof of concept. And the challenge you've thrown down there was thrown down to us in our advisory forum, and that's one of the reasons we're doing a proof of concept study.
Thank you. Any more questions? Then I have a question to the panel, and it can be for all of you, or one of you might want to answer. So now you have heard all about the laborious tasks in the hospital labs to actually identify a flu sample and report it to the various surveillance systems. You have heard about the work in the reference lab, where all the sample or the results from the hospitals are gathered and then forwarded to the international surveillance systems. So now, as most of you here have a background within clinical virology, you would be the right people to answer these questions as well, along with the panel. So how do you vision in the future? How do we actually ensure that if a new influenza virus occurs somewhere at your hospital, and you know that you need to sample, I don't know how many thousands of samples to maybe discover this one, and then maybe your system, either your commercial assay is not geared to actually discover it, or your PCR shows that something fishy is going on, but you simply don't have the time to forward this sample to the reference lab. How do we actually stand united for the future to ensure, as we're all working for the government, we're all working for the sake of the patients, and it's a laborious task to get all of these systems working every day for all of us. How do we ensure that the rare samples, the rare diseases are actually captured by the existing systems that we have in place? Do we need to have some mandatory reporting? Do we need to have mandatory surveillance where you are actually punished? Like we heard from the HIV, there is actually law involved in some countries. Or do we need to have more information out to each and every one of the hospital labs? Like Bert says, there's so much data, we don't need all of it, but actually to make sure that we capture the essential data when the need is. So this is an open question. How do we actually make sure that that sample is tested and that the sample is forwarded to the reference lab and is reported internationally? Thanks, Katja. Would like to take an answer on that one.
Yeah, well, I mean, Kim already showed that there is a lot of things to report, and at a certain point, especially for the exceptions, I think you sometimes also have to trust your professionals. I think we are all here as clinical virologists, molecular virologists, there's a lot of knowledge. I mean, how can you ever prepare for the unknown except for having your professionalism and think, hey, this is weird. And this is usually how discoveries work. So that's my opinion.
Thanks. There's one more comment up here. Yeah.
Thank you. Well, this is a very relevant question. And there's actually a big European consortium called Prepare, which is about being prepared for exactly this kind of event. So I don't know how many people here might be part of this consortium, but that's exactly the kind of things that if you think you might be confronted with a new outbreak, that's the kind of network maybe you should get in touch with, because that's exactly why it was created, and they have a lot of procedures for these kind of things.
Thanks a lot. That's a great input to all of us. Thank you. Any more comments on this, Peter, here in the front? Sorry, and I also have my panelist here. Thanks.
So I think what Katja said, it has to also deal with trust, because I've been trained in the clinical lab, and yeah, you often see your colleagues run away with your data, and I think we need to trust each other that epidemiologists or public health officials don't run away with your data. We need the data to prepare for an outbreak. The data is yours, and I think it's a matter of trust. I think we need to work on that. Yeah.
Thanks. And Caroline?
Yeah, Thea, so if you mean a new influenza virus that could potentially cause a pandemic, I mean, this has been captured in the international health regulations, which is a global agreement among member states, and in those regulations, all countries must have the capacities to detect, report, and respond to such a case. And there's a lot of WHO guidance on how to do that, and of course, clinicians and clinical virologists are absolutely crucial, because often it's in the lab that something like this is picked up. And so there's the formal side of all clinicians should be aware of what are those threats that could come out of the blue. So that's part of, I think, the continuing medical education of infectious disease clinicians. It could happen anywhere. And I think what I think first colleague said, it's about recognizing something weird. It's the astute clinician that says, hey, this is not, this is unusual. This is not a normal respiratory infection. And also what colleague said about including travel history and I think vaccine history and maybe other things in the standard reporting, that could also be part of it.
Just going to go along the line. So I think, as Caroline said, that the IHR provides really great structure for this, but it's really, I think the other answer is about awareness and education. I mean, you look at the white powder incidents, the anthrax in the USA, you look at SARS, which is a longer and more complicated story, but it's someone being alert to this being unusual, and I think it's about actually education. The other thing is you look at statutory legal requirements for notification in countries. Not all diseases are reported with the same degree of compliance, and I know from my experience that in the UK, TB gets notified much more reliably than many other notifiable diseases, and I think that's for two reasons. One, it's generally perceived to be a serious and important infection, and perhaps more importantly, it's because the nurses in TB clinics do it.
Thank you. And one last comment from Peter Coyle, then unfortunately we'll have to close the session afterwards.
So as a nerd virologist, I plot the numerator denominator of all respiratory viruses and enteroviruses every week. So if I saw a flu egg going up that was not typing, I think that would be pretty obvious. It's something pretty, from a virology point of view, abnormal.
Thank you so much. And now, as we have a tight program this afternoon, and in a minute we will turn this auditorium into a live studio, not from Hollywood, but from Copenhagen today. And we will have our own ESCV This Week in Virology, hosted by Vincent. I would like for all of you to stretch your legs if need so, and please be back in 4 minutes in the auditorium for the next session to begin. Thank you so much, and let's give the panel a big hand.